Hello, everyone, and welcome to the fourth episode of the CNS Controversies and Neurosurgery Podcast. My co-host, Dr. Seth Oliveria, and I, Rushna Ali, are excited to hear our guest speaker today, Dr. Kelly Foote, who is a professor of neurosurgery at the University of Florida, talk about the nuances and the controversies associated with selecting GPI versus STN targets for Parkinson's disease. Welcome, Dr. Foote. To start off the conversation, who do you think in your practice or even outside of your practice is an ideal candidate for STN versus GPI DBS?
Oh, well, I certainly gravitate toward STN DBS in patients who have debilitating intention tremor. And to some degree, even people who have severe resting tremor. I feel like we do a little bit better in STN, at least in the short run with resting tremor. Over time, STN performs better at suppressing intention tremor. So that's one of the main things I sort of gravitate toward STN for. GPI, the thing that I see most frequently that makes me really want to be in GPI rather than STN are patients with severe motor fluctuations that have debilitating dyskinesia. I feel like we do a much better job suppressing dyskinesia with GPI stimulation than STN stimulation. Those are sort of off the bat the two things that push me in the direction of one or the other. And then there are a bunch of softer indications for both. I think in general, GPI is a larger, more forgiving target. So if your objective is to stimulate for therapeutic benefit with the least possible disruption of normal information flow, meaning disruption of surrounding circuitry that you would rather not disrupt, it's easier to do that in GPI than STN.
So you mentioned some of the softer indications, and since this is Controversies in Neurosurgery podcast, what are some of those softer indications? If you want to delve into some of those.
Well, if you want me to be controversial, I would say if you are not good at targeting, meaning if you use indirect targeting of stereotactic targets based solely on the relative position in an atlas to the mid-commissural point, then I think you should absolutely use STN only. I think I made the mistake in the past of assuming that people who were asking me, when would you use GPI, were targeting with indirect targeting methods and optimized imaging. And I think one really important thing to understand about the two targets is what I believe to be the reason that Benabid gravitated toward STN as a better target in the first place, which is the position of the subthalamic nucleus relative to the mid-commissural point is much more consistent than the position of the internal globus pallidus relative to the mid-commissural point. So if someone asks the question, what are the coordinates that you target for GPI, that person shouldn't be targeting GPI because they're highly variable. And I think I actually, when I was working with Professor Benabid, I looked back at his GPI cases. And of course, he did 15 GPI DBS cases trying to recapitulate the pallidotomy experience before he started doing STN DBS. And the STN DBS experience was based on the work of Malin DeLong and others. And interestingly, he got much more consistent results in STN than he did in GPI. And I looked back through his GPI cases, and as best I could, measured the position of the DBS leads with the imaging that admittedly wasn't super high quality back then. But I believe that I found a correlation, and he had essentially 5, 5, and 5. He had 5 really good results, 5 sort of, patients who did really well clinically, 5 who got some benefit, but it was sort of disappointing, and 5 who had bad outcomes, meaning, not worthwhile outcomes. And when I measured those, what I believe I found was that those 5 who had bad outcomes were not, their lead positions were suboptimal relative to the internal globus pallidus. So I think with using the methodology of targeting we were doing at the time, which was ventriculography, stereotactic ventriculography, and indirect targeting based on the ACPC coordinates, I really think that STN is a better target because it's more consistent in its position relative to the mid-commissural point.
So, Dr. Foote, the guidelines for these 2 targets suggest that really kind of the motor outcomes are similar, regardless of the target, and that's sort of been the result of kind of several clinical trials. But as you alluded to at the beginning, I think we all believe that there are differences in terms of motor outcomes. What are your thoughts about that?
Well, I think that our outcome measures are insufficiently refined to really character and frankly the N in the studies that we run to try to compare them are, so we have insufficient power and outcome measures that are not refined enough to pick up some of the subtle difference. So I think that's part of the problem. But I do think that the finding that has now been concluded from multiple studies that the motor outcomes are similar is a valid finding. So I don't think, in the beginning when we first started doing our STN versus GPI prospective randomized trials, we were anticipating that one target was going to be better. And the conclusion that we reached and that others have since reached, I think, is that with regard to motor outcome, at least one of the targets is not clearly superior than the other.
And then one other thing I was going to ask, I know that, you kind of glossed over this. We kind of talked about the patient who's the ideal one for certain targets, but kind of the asking the question in reverse, are there times when you would specifically avoid one target for a certain patient versus or a certain target versus the other for an individual patient?
Oh yeah, actually, I think that question is every bit as interesting as the other question, and useful. Certainly, the patient who has, I can answer in reverse. The patient who has severe dyskinesia that are very problematic, and that they list among their top couple of complaints. That patient, I avoid STN because in some trivial percentage of STN DBS patients, we actually induce dyskinesia with stimulation, and we have a really hard time controlling the dyskinesia. So if the patient says, the one thing that bothers me the most is the dyskinesia, which is the minority of patients for sure, but if I ask every patient before DBS when I first meet them, what are the symptoms that bother you the most, and let's rank them in order of most to least important to your quality of life. And if if they list as number 1 or number 2 problematic dyskinesia, then I actually avoid, I'm nervous about STN in those patients.
Mm-hmm.
I would say GPI is, as I mentioned earlier, sort of a forgiving target, and so always minimizes risk associated with stimulus of or disruption of surrounding circuitry. And in our original STN versus GPI trial, the compare trial, where we randomized a bunch of patients, there were a couple of really interesting findings. One was that we didn't dwell on too much, really, but I think it's an important one. There were substantially more mixed circuitry adverse effects in the STN group than in the GPI group. So people who have severe anxiety disorders, comorbid depression, significant psychiatric circuitry disorders, along with Parkinson's disease, I sort of shy away from STN just because I think it's a little bit harder to not spread current into the limbic circuitry in STN. It's a little bit easier to do that in the GPI because they're more physically separated. While I'm on the topic of the compare trial, and relevant to the question you asked, in the compare trial, every once in a while I would get a patient who had severe dystonia. And dystonia was by far their worst and most problematic symptom. And in those patients, I, at the time, was very nervous about STN DBS for Parkinson patients with severe dystonia as their primary problem. And I think had we not been randomizing patients at the time, I probably never would have used STN in that population of patients. But those patients who had dystonia as the primary problem, who got randomized to STN, actually did beautifully. And there really was no difference between STN and GPI for the treatment of dystonia, although I think a lot of people still sort of gravitate toward GPI in patients who are primarily dystonic. But I'm not as nervous about that as I used to be. It works great for that.
Yeah, that's really interesting. And you could we have another Controversies podcast about using sort of STN for primary dystonia, but I know there's some people who are interested.
Yeah.
But go ahead, Rushna.
So really interesting point about avoiding STN in patients with bothersome dyskinesias. Just to elaborate, have you elaborate on that a little bit further, Dr. Foote. Now, most often, Parkinson's patients have dyskinesias that are medication-induced, and most of the community still thinks that with an STN target, you can come down on their dopamine medications a lot more easily than with GPI, although there's evidence suggesting otherwise. That GPI is pretty great for medication reduction as well. So keeping that in mind, how would you go about counseling your patients, or training your young fellows as they come through on how to balance the two out, medication reduction versus potentially stimulation, having to deal with stimulation-induced dyskinesias with an STN implant?
Sure. I think the data is pretty strong, actually, on medication reduction. And I think even though, people point out, some problematic things like maybe they didn't try as hard in GPI or whatever, we found in our prospective randomized trial that our STN patients had more medication reduction than our GPI patients, and I haven't seen a trial that has found the opposite of that. So that is a true statement that I believe. So if your primary goal is medication reduction, then I think STN is a better target. I will qualify that in a couple of ways. Medication reduction not a long-term solution, meaning, if you look at 1 year or even 2-year outcomes, then the STN, the meditation reduction you get in STN is terrific, and the patients are happy with that. But the truth is, my objective is rarely to get the patient off their medication. My objective is to make the patient the most highly functional human being that I can make them. And you almost always accomplish that with a combination of medication and stimulation. And over time, you sort of maximize the beneficial effect of the stimulation once you're optimally programmed. And you can't really turn it up to get more effect, or you'll cause stimulation-induced adverse effects. So you're left with, in the long-term, really medicated adjustments. And I think that GPI long-term is a bit more forgiving, because I will grant that you can achieve reduction of dyskinesia in STN by reducing the amount of medication that the patient takes. But in some population of patients category, you're going to, in the long term, run into medication dose limiting dyskinesia, and there's a small percentage of patients in that category who have STN DBS at 5 years with problematic dyskinesia. We rescue with GPI. So I mean, those are things that sort of go through my mind. My primary objective is not usually these medications. I mean, that is a standard effect, but it rarely ranks at the top of the list. Occasionally it does. In patients who have problematic dyskinesia and in whom we achieve dyskinesia reduction by stimulating an STN, alleviating their motor symptoms, and diminishing the dopaminergic medication that they take, that I will grant that is a great solution, and patients are happy. Some percentage of those patients who are initially happy, however, in the long term, will develop, once you get the maximal beneficial effect from stimulation of the STN, and you're left, as the patient's Parkinson's disease progresses, with medication adjustments as you're really your only tool left. Some of those patients will have dyskinesia even with STN stimulation that is dose limiting their medication, and in some small percentage, we end up rescuing those patients with GPI stimulation, or adding GPI stimulators just to alleviate their dyskinesia. It gives them a little boost in their reduction of motor symptoms with GPI stim, but it also suppresses the dyskinesia and enables you to use medication in that patient population who needs it. So I guess the point is that GPI tends to be a more forgiving long-term treatment solution.
Dr. Foote, to try to push you towards something more controversial here. Not that you haven't already said several things. So if you were going to hazard a prediction, do you think there's any changes in sort of what we've talked about that are coming with as we use more directional leads?
Well, I worry. I worry that people are overconfident in the ability of directional leads to compensate for poor targeting. And if people become less meticulous and precise and careful in their stereotactic targeting because they think, well, it's a directional lead and you can remediate a poorly placed DBS lead and you can still get a beneficial effect. I think if that is a prevalent attitude, then the entire field is in trouble, because the amount of directionality that directional leads provide is very small, and And I still believe, even with the best directional leads, that no amount of expert programming or directionality can compensate for a poorly positioned DBS. Is that what you were hoping I would say?
Yeah, no, yeah, well, I didn't know what you would say, so that's why I asked it. And I guess, the opposite, so a well-placed lead, do you think that makes, for example, a well-placed STN lead, do you think it's a little more forgiving for that patient you might otherwise be a little nervous about?
Absolutely. In fact, there was a period of time where I was using one hardware manufacturer for all my STN cases and another one for the GPI cases for that very reason, because I felt like STN is a smaller target, it's less forgiving, and even that little bit of benefit that I can get from directionality in that small, unforgiving target is absolutely worthwhile. And, of course, I don't think it's bad to have directionality in the GPI target. I just think it is less critical. But at this point, I use directional leads for everyone, and I certainly think everyone should, because it's beneficial technology. I just think to be cautious about the attitude that maybe we don't have to be as careful in our targeting as we did before because of directional leads. I think that would be a major mistake.
In that same vein of technological advances, have you adopted closed loop stimulation in your practice, and how has that changed the algorithm for you?
Closed loop deep brain stimulation for movement disorders is, of course, investigational at this point. So the answer is yes. I have a handful of patients out there on experimental protocols with Tourette syndrome and Parkinson's disease who are actively in closed loop mode. But I think it's not ready for prime time. I think intuitively it makes sense that having therapeutic stimulation that optimizes itself based on some meaningful neurologic signal, some meaningful biomarker, is going to produce better outcomes. And right now we use sensing in the vast majority of Parkinson's patients, and we record and we look at beta signals, various contacts, and we try to use that in conjunction with our lead localization and depictions of the contacts in three-dimensional anatomical space to optimize our programming and simplify our programming. But of course, it's not quite ready, and I think in 10 years, maybe 15, all DBS will be adaptive. I just can't imagine that we wouldn't exploit that possibility of responding, because none of the disorders we treat are static disorders, right? And brain circuitry is not static, so we need to optimize things. We need dynamic changes in stimulation, and as the technology improves, becomes more complex, we right now the programming solutions are falling behind the technological advances. So if you want to exploit all of the technology available currently, it's really a time drain on the programmers. It takes a lot of time and energy, and it's not practical for high volume centers to do that on every patient. So I think adaptive DBS ultimately is going to result in devices that, with some help, essentially program themselves and optimize outcomes.
Fantastic. If there are no other questions, we will wrap this up. We thank you for your time and for this great discussion. And a big thank you to all of our listeners for tuning in for this podcast. Please follow us on social media. Our Twitter handles are @Rushna Ali 6 and @Seth Oliveria, as well as @CNS Update. Please follow us for upcoming podcast episodes and other educational material. Thank you, everyone.